Right, so this is Nate and Korina, and we are doing ours on narcolepsy. So people who are diagnosed with narcolepsy are experiencing extreme daytime tiredness, cataplexy, sleep paralysis, abnormal REM sleep behavior, and hypnagogic hallucinations. All of these things will clearly impact your functionality and day-to-day productivity. And also, some of these symptoms are going to be kind of dangerous. So the daytime tiredness is also not only a long-lasting, dull kind of underlying tiredness, but it also can come on in really intense, they're called sleep attacks. And this can be really dangerous if you're driving or just somewhere where you shouldn't be falling asleep. Cataplexy is a muscle weakness, and the hypnagogic hallucinations can be really disorienting. They can be auditory and visual, and they can make you feel like you're spinning. So all of these things obviously are not desirable symptoms and are going to really impact people. And what we've noticed is that people who start experiencing these symptoms sooner in life, in their childhood, will experience the symptoms of narcolepsy more intensely throughout their adulthood. So an earlier diagnosis is often related to a more extreme case of narcolepsy throughout your adult life. And then, as we're going to see in the next slide, is a diagram broken down to the demographic of people who are diagnosed with narcolepsy. And what we see is the majority are white female of middle age. And there is also a difference between narcolepsy type 1 and narcolepsy type 2, where narcolepsy type 2 individuals don't experience cataplexy or a decrease in hypocretin levels, which will explain most of those things more later. So this is the diagram that we collected from the Nexus Narcolepsy Registry, which we'll also talk about more later. So you can see the main symptom so this is a collection of symptoms that led people to getting their diagnosis to narcolepsy. So these are their first reported symptoms. And most people who are diagnosed with narcolepsy are experiencing, I believe this is 6 symptoms. Most people experience 5+ symptoms of narcolepsy. So it's not just excessive sleepiness. Most people are experiencing almost all of these. But the main report is the excessive sleepiness with a 92% of people, almost 93%. And then we go down the list: trouble concentrating, focusing, poor school work performance, the hypnagogic hallucinations, and then the episodes of knee buckling, jaw sagging, and head bobbing. That's the cataplexy, the weakness and muscle definition. And tone, and then frequent sleep paralysis and other episodes of weakness in the face, hands, and limbs. All right, and I believe that was a sample collected from 1,024 different patients diagnosed with narcolepsy. Okay. And then the affected genes. So we see the DQB10602 gene allele most closely related to people experiencing narcolepsy and cataplexy. It is closely related to both of those together, which comes up a lot, and we'll talk about that more. And the DQB1 gene is found on the HLA complex, which is the human leukocyte antigen complex. This is located on the 6th chromosome. The HLA complex is responsible for coding surface cells in the immune system, and we'll we'll see how your immune system also affects is related to narcolepsy as well. And let's see, yeah, so I'll on the next slide. Oh, sorry. Okay, and then the DQB1 gene works in tandem with the DQA1 to produce a functional protein complex called an antigen binding DQ alpha beta heterodimer. This heterodimer introduces foreign peptides to the immune system, allowing a response to be triggered. Okay, and then this is the chromosome 6 with the gene locus here, the 6p21, which is broken down into 3 classes of genes. And the second class, the red one, is where we find the DR and DQ, which are notable genes, the DQ in particular, which has the O602 allele that is like really strongly correlated to cataplexy and narcolepsy.
Okay, so now let's talk a bit about the mechanics of the mutation. First of all, hypocretins are neurotransmitters that bounce signals between neurons in order to maintain alertness and keep REM sleep from occurring at the wrong time. And narcolepsy is caused by a lack of these hypocretins in the brain. This hypocretin deficiency leads to REM cycles mixing in with wakefulness, causing the multiple symptoms of narcolepsy. Alleles other than O602 of DQB1 have not been identified in possible causation of this disorder. And it's been found that 98% of people with type 1 narcolepsy and 50% with type 2 have this O602 allele. So a study was performed to specifically focus on the correlation between the allele and narcolepsy. And while the results were partially inconclusive, the researchers hypothesized that the O602 allele and its formed heterodimer with certain DQA1 alleles leads to a specific unknown antigen binding that targets hypocretin producing proteins to keep them from being created. This O602 allele is almost always present in tandem with DRB1 and DQA1 gene alleles. However, researchers have been unable to identify whether these additional genes are involved in increased risk of narcolepsy. This hypothesis that O602 is directly a cause of the disease is made more consistent with the fact that the allele expression and through that the severity of the narcolepsy in the individual is increased in homozygotes. This may be due to the heterodimers between O602 and other closely linked genes being less abundant in individuals that are heterozygous for the allele. And this hypothesis is backed up by expression test results, including fluorescence tagging, to observe heterozygous and homozygous mRNA production of the O602 allele, and I'll talk about that a bit in the next slide. Additionally, in canines, it was found that a disruption mutation causes an amino acid deletion and a frame shift and premature stop codon, which is a mutation that affects the HCRTR2 gene, which codes for a hypocretin receptor protein, leading to the loss of function of the gene. So in canines with this mutation, they don't have hypocretin receptors, and that leads to narcolepsy. In mice, a nonsense mutation was found to have the same effect. And while these mutations are not present in humans, they lead to a better overall understanding of the disorder because we just don't know a whole lot about it. Here are 2 graphs I was talking about a second ago, and they just kind of demonstrate how in homozygous individuals with the O602 allele, expression is much greater. So you can see both with the fluorescence intensity and just overall mRNA expression, there's a lot more of that O602 allele in homozygotes.
All right, so genetic testing. So going back to those 2 different types of narcolepsy type 1 and type 2, individuals with the type 1, over 98% of the of individuals with the type 1 and 50% of those with type 2 carry the DQB10602 gene allele, and that can be used to help identify narcolepsy. However, 15 to 25% of the general non-narcoleptic population also has this allele. So a negative result for the 0602 allele is a good sign, but if that you're not affected by narcolepsy, but a positive result is less impactful because to confirm your diagnosis of narcolepsy, because that the like I said that we also carry the allele. So you also have to kind of put in some additional genetic testing to get an accurate diagnosis of narcolepsy. In addition to that, you would use a sleep latency test, which is not genetically based, but they will do they'll take a sample of a patient's cerebral spinal fluid, and they'll test for the concentration of hypocretin, because as we mentioned earlier, a deficiency of hypocretin is kind of indicative of having narcolepsy, especially if that individual already has the 0602 allele. And what they're looking for when they get that sample of cerebral spinal fluid is a concentration of less than or equal to 110 picograms per milliliter, which is enough to diagnose narcolepsy type 1. Oh, and then this is a quote that we pulled from Science Direct by those authors below. And it says, in summary, in contrast to animal models, human narcolepsy, although specifically linked to hypocretin deficiency, is not a simple genetic disorder, but rather a complex disease, including not only disturbances in other neurotransmission pathways, but also an as yet unknown immune mediated mechanism associated with a specific HLA haplotype in interaction with environmental triggering factors, which kind of just brings in all of those different fields of study that are going into narcolepsy, because it's kind of inconclusive at the moment.
There also is no direct cure for narcolepsy, but there are a number of options for people to manage the disease. There are simple counteractive measures like frequent and scheduled naps, a strict sleeping schedule, having relaxing bedtime routines like yoga or a hot bath. A comfortable and quiet sleep environment is really important for people with narcolepsy, and they should also be avoiding caffeine or large meals before bed. If these home remedies are not effective enough, people can turn to stimulants and antidepressants. Stimulants like modafinil and sodium oxybate are used to combat effects of narcolepsy by stimulating the central nervous system, which keeps people awake. The use of antidepressants such as SSRIs is less effective, but can be used to treat symptoms like loss of muscle control, which is just cataplexy, hallucinations, and sleep paralysis. These antidepressants work by altering brain chemistry to reduce the amount of REM sleep one experiences. Both the stimulants and antidepressants have some pretty heavy side effects like constipation, dizziness, insomnia, blurred vision, nausea, nervousness, irritability, which are said to diminish over time of use, but that's still something difficult to deal with. Additionally, narcoleptic people can seek out therapy or psychiatric help, because this is a lifelong disorder that can have a pretty drastic effect on your mental health, and it's important to receive professional assistance or input dealing with that. So because there is so much unknown with narcolepsy and how it's inherited, what the genetics of it are, there are a lot of paths for future research. And one example of this is a study covering a large family that has 12 affected members diagnosed with narcolepsy type 1. A genome-wide linkage and exome capturing were used to identify a possible causative mutation. The performed exome sequence found a single nucleotide missense, changing a C to a G on chromosome 6, where the HLA complex is located, and that was present in every affected family member, but none of the unaffected family members. So this additional cytosine created by the mutation is postulated to lead to either the disruption of myelin producing proteins or an increased and extra production of myelin proteins. This mutation was then genotyped in close to 800 unrelated individuals, half of them with narcolepsy, and none of them carried the mutations. They found a number of other rare variants, but none were considered to be pathogenic. So this mutation is exclusive to the family and only members of the family that are narcoleptic. And while there's no direct correlation to anyone outside the family, this mutation identification has provided researchers with information on the development of the disorder and its possible links with myelin, oligodendrocytes, and hypocretin deficiency.
All right, and then another approach to filling the gap between, like the knowledge gap with narcolepsy, is obviously collecting data from as many patients as possible. So there is an online research platform that was developed by academic researchers studying this topic, advocacy groups, and a pharmaceutical company. It is compiled of many surveys that you take over the span of several months, and you're required a diagnosis of narcolepsy and a submission of your sleep latency test to participate. So there are a few limiting factors to the Nexus Narcolepsy Registry, which is you have to have internet access, you have to be 18 years of age, and the surveys are in English. So you have to have English proficiency to be able to take it. So of course, these are limiting factors for a complete data set. You know, and you also have to be able to have access to that diagnosis to narcolepsy initially. There's lots of undiagnosed cases out there. So this is not a complete set. And then this is the same site that we pulled one of our earlier figures from, which was compiled of 1,024 narcoleptic patients, and that was by 2017. So they were able to get a decent amount of data from this. And let's see, some things the surveys cover are the age of the narcolepsy symptom onset, current symptoms, cataplexy symptoms, frequency of the sleep attacks, triggers that might induce the sleep attacks, time of day that they come on, previous misdiagnoses, and then age, gender, race, and geographic location to kind of continue trying to further connect potential genetic inheritance and like relationships to narcolepsy and those it affects. And yeah, I'd say on the next registry.
Earlier, we were talking about how narcoleptic patients that had a earlier onset of the disease had more severe and frequent symptoms. And this kind of correlates with a positive family history of the disease. So having family members that are narcoleptic makes a child more likely to also be narcoleptic, which suggests that the age and onset is genetically determined. So that is a big thing that researchers are starting to look into. And moreover, greater research into the relationship between the O602 allele and the genes it forms heterodimers with could provide us with a better understanding of the genetics of the disease and how exactly this O602 allele plays a role. Here is our bill. We're excited. That is all we have for y'all. Thanks for listening.
Thank you.